Hi, I'm Michelle Grzoulis, and I'm president of the Foundations at Rochester Regional Health, and I'm here today with Dr. Mroueh and Dr. Hayes, who are both reproductive endocrinologists at Rochester Regional Health, to talk about fertility, a subject that is personal and for many people one that's fraught with a lot of emotion. So we'll get to that in just a second, but thank you both for being here. So glad you're here today.
You're
Thank you for
welcome.
inviting
Thanks for
us.
joining us. For the listeners, please, if you have any questions as we're going through our discussion, send them in and we'll take a break and ask those questions. And so again, thanks for being here. So our topic today is fertility care, and that can be a really broad topic, and as I said just a moment ago, probably one that's deeply personal for a lot of people. And I always start with this, I always end with this question, but I'm going to start with this question first with both of you. Dr. Mroueh, why did you get into reproductive endocrinology?
Well, I always wanted to be a doctor, and I always wanted to be in women's health. So that really was not, something I thought much about. But it's a little strange because I always thought that the earth was overpopulated and I wanted to do more contraception than fertility. And then one day, working with people and seeing the suffering they go through to have a baby, and it's something that I feel very, very strongly about, which is, having children, raising children. I mean, I can't imagine my life without my kids. And that's honestly was really the way why I decided to go that way.
Interesting. Dr. Hayes?
So I decided that, first of all, the quality of life in the world of medical care was important to me over quantity of life, and that OBGYN and reproductive endocrinology were a happy place. There's a lot of death and dying in medicine, and having births is a great joy. And it's a field that, at least in the past, was very focused on surgical care, and I surprised myself and really enjoyed being a surgeon.
Really? And how long have both of you been with Rochester Regional Health?
We joined the Rochester Regional Health almost 2 months ago, but
Okay.
we've been, since the practice was started many years ago, more than 20 years ago.
I joined in
Yeah.
1991,
Okay.
so
Great.
a long time.
Great. Wonderful, wonderful. Thank you for sharing that. I think it's always a
Sure.
really interesting, I've learned more about why physicians choose certain fields of practice, and I think it's just very interesting to hear what draws you to one thing versus the other. So from my own experience as well, I think starting to talk about fertility, especially when people are struggling with infertility, is always challenging. So let's talk about some of the media perceptions, and I'll throw this out to both of you, and one of you can jump at it. But how common is infertility?
Well, officially, it's reported to be 15% of couples are going to have difficulty having a baby. And usually it's defined as if you've been trying for a whole year and you did not get pregnant, then you do have infertility. And when they look at the number of people trying and who don't get pregnant, it's considered to be 15%. Now, this has changed a little bit for older women. Older is really a misnomer. A 35-year-old, a 36-year-old woman is not old at all. But
from fertility standards.
But for fertility,
yeah.
they consider that if a woman has been trying for 6 months and did not get pregnant, then she needs to seek fertility care and make sure everything's working well, and hopefully, ask her doctor to help her conceive.
So I want to go back and say that again to make sure that we get it. So general rule is if you're over 35, if you're female and over 35, and you've been trying for more than 6 months and haven't conceived, you should consider talking to your
doctor
physician.
about
Okay.
that.
Okay.
There's a couple of other caveats with that, and that is if a woman does not have regular menstrual cycles, so she's not ovulating, by definition, she has infertility.
Okay.
And there is no such thing as trying to get pregnant in the absence of ovulating.
Very good point. Very good point.
Yes.
And I would imagine that the stats on this are probably low because there's probably people who struggle with this and actually don't know that they're struggling with infertility as a diagnosable kind of issue, right?
Oh,
Right.
exactly. A lot of time we see people who've been trying for like 3-4 years, and
Yeah.
like, what have you been waiting for? And like, oh, we thought it was normal,
Yeah,
No, it's
right.
really not normal. Or, there are some people who might be told, family and friends, oh, it will come, just keep trying, And that's why, it's really good for, for patients, for people to remember that definition, 1 year or 6 months, depending on your age. And it's really time to see, an expert in the field.
And I want to ask this to make sure I didn't miss it. So over 35, I got that, if you're over 35. If you're under 35, it's really if you've been trying for a year.
For a year,
Okay,
exactly.
okay, so general rules. Let's talk a little bit about the primary causes. Dr. Hayes, what are some of the primary causes of infertility or fertility issues?
Right. So one is ovulation problems. That's the number one. There are some women who are incapable of ovulating on their own. The number one cause is polycystic ovarian syndrome. Those women technically have plenty of eggs, but don't ovulate normally. On the flip side of that, there are women who have ovulation problems because they have an inadequate number of eggs. So those are two common problems we see. Secondly, we see male factor problems. So after egg problems, sperm problems are an issue. So we're not treating only the woman, we're treating the couple and sometimes focusing on male factor issues. And thirdly, there are issues that involve the fallopian tubes in the pelvis. That includes endometriosis, scar tissue from infections or surgery. So that encompasses the bulk of what makes things up.
As I was listening to you talk about the primary causals or reasons, issues rather, I would imagine it's so emotional for couples to talk about because it can feel as if this is something your body should be able to do, and so there's blame that's attached to that. And so I would imagine that sort of getting into that this is probably emotional conversations as well.
It is,
Yeah.
and we have tissue boxes close at hand at all times.
That's understandable.
But I want to assure anybody that there is no finger pointing, there is no blame. This is a medical issue. Things are focused very much on the medical aspects of things, figuring things out and addressing those things in an optimum way.
One of the issue, I
important.
guess, that's so frustrating. So many women will be using contraception for 5, 10, 15, 20 years, trying to prevent getting pregnant, and then suddenly, what do you mean I can't get pregnant? I mean, I've been using pills, I've been using, IUDs or whatever for all those years, and it's really frustrating because, they were told growing up, try not to get pregnant, you're too young, you need to finish your studies, and suddenly, like, why it's not happening?
Exactly.
That should be, like, so easy,
Yeah.
relatively speaking. So there is a lot of frustration, and, we always bring up this point that there is really no blame. It's not my fault, it's not your fault. You're a couple,
Yeah.
we're working with a couple, we're trying to have a baby. And because sometimes, rarely though, you see a little bit of finger pointing between the couple. Oh, it's your fault, or, unfortunately.
Yeah, yeah. So with those three, you talked, I think, about three primary. Let's talk about the treatments that are available at Rochester Regional Health. So let's start with polycystic ovarian disease. What are some of the treatment?
So the
protocols.
treatment for that is ovulation induction. So that means taking fertility medications to make a woman ovulate normally.
Okay.
Generally, that starts with pills, fertility pills. And if that is successful, we're happy. And if that's not successful, then we go on and use injectable fertility medications.
Okay.
Okay?
Okay. Dr. Mroueh, some of the other treatment options.
Well, one of the main cause of infertility, as Dr. Hayes said, is a tubal disease, like the tubes are
Yeah.
blocked. And in this case, there is surgery, try to unblock the tube, try to fix the tube. And usually it's minimally invasive surgery, the patient comes into the hospital, have the surgery, goes home. And another issue, if we are unable to fix the tubes, which happen, a lot of time, then the second option is going to be to do in vitro fertilization.
Okay.
And that's really like, and in vitro is successful, in vitro works well, in vitro has been used for now 30, 40 years with very, very good results, and that's another option available to couples.
Is the biggest reason that people, I've never been through this level of infertility, but in vitro fertilization, is that expensive?
It is expensive,
Relative to other,
right?
yes.
And one of the issue with in vitro, it's because expensive. A lot of insurances did not cover it. It's around, if I'm guessing a price, anywhere between an average of $8,000 and with medication maybe $10,000 to $11,000 for in vitro. The good news, though, for our listeners is that as of January 2020, New York State has passed a law whereby employers who have more than 100 employees are obliged to cover 3 in vitro fertilization cycles.
Wow.
So that's really gonna be like a big relief for so many couples who thought for many years they couldn't have a baby, they couldn't afford to go through IVF,
Yeah.
and hopefully that will, that will be very, very helpful in treating those patients.
That's actually, because one of the things I was going to ask you about was the cost and what could healthcare and insurance organizations do to make it more affordable. That's clearly one step.
Right.
And another interesting fact is that New York State also has passed a law that for patients who are on Medicaid, as of September also, they will be covering not every treatment for infertility, but at least some preliminary, some basic treatment like inseminations, like the drugs Dr. Hayes talked about to induce ovulation, like testing the person to see what's the cause of infertility, etc. So I guess, things are improving from an insurance point of view, and that should help a lot of people, going forward.
I think you were going to say something
Yeah,
else.
Rochester Regional Health has extended a payment plan option so
Okay.
that people who want in vitro fertilization and need to pay out over time as opposed to paying a lump sum, then arrangements can be made for that. So
Okay,
that was
that's
a very good thing as well.
Let's go back to the treatment options. So we talked about a couple. Are there other things that you think are important to share when people think about basic issues with infertility? Because I think we're demystifying it a little bit. I think it's this sort of unknown area.
Well, I think one of the things is artificial insemination sounds like a big thing to
Yeah.
a lot of people, but I think they find out when they're involved with it that maybe it's not such a big thing.
It can be scary, I'm sure.
Right, I think it sounds worse than it
Yeah.
is, and
Yeah.
usually when we perform this for the first time, people go, "That was it?"
Wow.
It's almost a letdown because
Yeah.
they think it's something bigger than it is.
I always try to avoid the word artificial insemination
Yeah.
because, people may get scared. But then I always say, you know what, people come on the lunch break, have it done and go back to work.
Yeah.
Yeah.
So it's not like,
Yeah, it's different.
Yeah.
It probably carries with it
yeah,
more baggage
it's a
than it
really
used to.
simple
Yeah.
procedure,
Yes.
do it, go back to work. You're not going
Yes.
to feel anything. You can resume all your activities.
Yes.
It's such a simple procedure. And I mean, we get really good success with it. We get so many pregnancies with it.
I was just going to ask you a general rates of success kind of question, and I'm sure that's dependent upon the type of fertility treatment. But share with us a little bit about rates of success. What are the most successful infertility treatments that are available for people? What should the person listening who may be wondering, hey, if I'm struggling with potentially infertility, what should I be thinking about as what might be successful?
Okay. So, I always bring up the normal reproduction. I always tell people, for a woman who's 18 years old, who's having sex every day of the week, 3 times a day, at the end of the month, the chances of getting pregnant at 18, which is like the optimal age, is not going to be more than 35%.
Wow.
It does sound low, but this is human reproduction. We're not a rabbit. We don't just, reproduce right and left. And what we try to do with all the treatment that we have available is reach that level. And the only way we can beat up this level, do better, is when we do in vitro fertilization.
Okay.
Rose, you want to add?
So, yeah, when you break that down into fertility treatments, fertility treatments are better than no treatment
Yeah.
for couples that are having difficulty, but they don't reach the level of in vitro fertilization or normal.
Okay.
So, for example, if somebody's using fertility pills coupled with intrauterine insemination or artificial insemination, their chance of having a baby on one try is about 10%.
Okay.
And if you change to injectable fertility drugs and you combine that with artificial insemination, their chance of having a baby on one try is about 15% to 20%. So it's better
Yeah.
than no treatment, but it doesn't normalize people.
Yeah.
And then as you take a step up in fertility intensiveness care, and you go to IVF, and a couple who's about 35 years old, they'll have about a 40% chance of having a baby successfully on one try.
Okay.
So, the higher levels of care do bring higher rates of success, but it does require higher levels of care.
Yeah, and I'm also curious in both of your long set of experiences in doing this, What percentage would you say of people that you've taken care of who you just have been unable to help conceive?
It's really a small percentage.
Good.
The majority, I mean, I like to quote that 95% will end up having a healthy baby and go home with a baby. But, sometimes it can be frustrating. It may take a little bit more,
Yeah.
Treatment, a little bit more time. But honestly, the majority of people do get pregnant at the end of the day, as long as they stick with treatment,
Yeah.
I mean, there is always like the patient who keep going to different places, changing, etc., hoping that things are going to be different somewhere else. And the idea is really to stick with the treatment, follow the steps, and, agree with the treatment that's being, offered by the physician.
And
That's
anticipate
really
that it's
helpful.
not going to be a quick
Yeah.
fix.
Exactly,
Well-
exactly. And I mean, we're very happy when it works for the first time. That's really the aim. But
Right.
unfortunately, sometimes it may take 1, 2, 3 tries
Yeah.
before it works.
Dr. Hayes, you were going to say
Yeah,
something.
I think one of the hardest situations is when people have to deal with the question of whether to use their own eggs or sperm or donor eggs or
Mhm.
sperm, because oftentimes what's not working in the reproductive system is the egg or the sperm, and if having a baby with that particular woman and that particular man's egg and sperm is the central issue, that can be extremely difficult.
That's complicated.
It's very complicated. If they say, well, I'm willing to use donor egg or donor sperm, or donor egg and donor sperm, egg and sperm that we know will absolutely work properly, then that opens up the success rates
Yeah,
dramatically.
Of course. And I'm curious too, are those, this just popped into my head, but are those issues of whether it's the sperm or the egg in requiring using a donor of either one of those more age dependent? Like, do you see that we're being required more for older folks who are, and I say
Yes.
older folks as in under 30, or
Yes.
Yes. Makes me feel very old.
No, the need for that does rise with age, but it is not exclusively age-related.
As I listen to the two of you, one of the things, and I'm sure folks listening would say the same thing, especially if you've been dealing with infertility, is it's almost like a puzzle, and each patient is a different puzzle for you, which is probably the same in lots of things, but what I hear you saying is treatment is very customized based on what we're actually dealing with, and while we may have 3 or 4 common issues, the reality is how we treat it is going to be very much what you decide works based on the uniqueness.
Yes.
Definitely. I mean, it's definitely not a cookbook approach.
Yeah,
Everybody's going
yeah.
to receive different treatment. Everybody's going to be managed very, very differently than
Yeah.
somebody else. One thing I wanted to point out is, what is success? Like, there are some places which will consider success a pregnancy, but a pregnancy that miscarry is really not a success. A pregnancy that never developed adequately is really not a success. So for us, success is a live
A
birth,
baby.
a baby born healthy. That's what we consider a success. So, and as I said, when people do look at success rates of different clinics, etc., they need to be careful and compare, apples
That's
to
a
apples
really
and
good point.
oranges to
Yes.
oranges.
That's a really good point. I hadn't even thought about that, but you're right, defining success as, our measure of success, your measure of success is a healthy baby being
in
born.
your arms,
That's
exactly.
yeah.
A healthy baby.
Yeah,
holding
that
in
is
your arms.
extremely
Very
important,
important.
and that's why in our field, with regard to research or the way people look at things, we caution against using what's called intermediary indicators. In other words, somebody might say, but I had a great estrogen level, or I made a lot of eggs, or I made a lot of follicles, but that's not success.
Yeah.
Only a baby is.
Only a healthy baby.
Well,
is
you
a
set
very-
a high
we're
bar for
very-
the measure of success.
Yes,
Right.
it's very bottom line.
So with that measure of success, when you say to us, the question I asked around success rates, for us to be at, say, 95% success is, I think, sounds pretty amazing.
I mean, it is a good number. But again, I mean, some people may be willing to go through some different treatments. Some people may be willing to use donor egg, donor sperm, etc.
So I want to talk about, so I was here yesterday interviewing folks for Pride this year. This month is
Okay,
Pride Month
sure.
in Rochester, and this weekend, Rochester Regional Health will have a contingency of folks walking in Pride for the first time. And one of the areas that continues to be talked about more and more is, how do you help LGBTQ folks fertility issues. So any work that we're doing in that space that you two are,
Sure.
I
Yeah.
mean, as far as I can remember, we've always been a very
Mhm.
LGBTQ, friendly practice. We do, we have a lot of, female gay couples where we use donor insemination. We have a lot of male couples, where we use donor egg
Eggs.
and the surrogate to carry
Yeah.
the baby with them, for them. So yeah, all the services are available to them at
That's
any
great.
point.
The other service that people ask us for is shared IVF cycle.
yeah.
So a lesbian couple, one can give the eggs and the other can be the
Carrier.
carrier.
Of the baby.
Which
So-
I've had friends do, which I think is pretty
Yeah.
amazing.
Right, so we're
Yeah.
happy to accommodate whatever
Yeah.
requests people are interested in.
Well, on behalf of the LGBT community, thank you for that.
Mhm. You're welcome.
So I'm also curious about, in your experience in the years that you've been doing this, how have you seen fertility treatment change? What are the biggest sort of ahas for both of you as you've moved through your career?
IVF was really like the big thing. And since then, I have to say, the problem again is like you're really working with only two things, that sperm and that egg, and you really need like those to be of good quality. So the last thing that's available now really is biopsy of the embryo to make sure, if the embryo, in case people want sex selection, they want a boy, they want a girl, so we can give them what they want. They carry a disease. Let's say a woman who carry the gene for breast cancer, BRCA1, and she doesn't want her daughter, her son to carry that gene. So, we can check each embryo, see which one carries it, which one doesn't, and then transfer the embryo that does not, or, cystic fibrosis or other genetic diseases. So all of these, are available. And I think really that's like the biggest breakthrough at this point, trying to evaluate the embryo, make sure it's healthy, make sure it doesn't carry any specific condition that we're worried about before implanting it
Yeah.
inside.
Also, I think our field used to be very heavy into surgery, and surgical care has decreased over the years.
Interesting.
So that's interesting. And in the old days, when we needed to use an egg donor, we had to go out and find a woman. A few years ago, egg donor banks
Yeah.
became legal, and boy, I'll tell you, that's made everybody's life a
Life-changing.
lot better.
Yeah.
So that's a good thing.
Because now, in the past, people wanted a sperm donor, they'll go online, or they'll look in a catalog, I want a 6 feet, blue eyes, whatever,
Yeah.
and they will choose. And now for eggs, it's the same. They
Yeah.
can just go online,
That's been great.
put the characteristics that they want, the religion, the height, the weight, and then see who's available and what's available.
That's amazing.
So
Yeah.
that's really
That's
make it
amazing.
really, really easy at this point.
Especially, I think it's amazing, and I also think it's got to be very comforting for people who physically don't have the eggs or don't have the sperm
Yes.
necessary to
receive
conceive.
Yes.
And again, there is frozen eggs, but we still use regular fresh eggs, a younger sister willing to give her older sister eggs, family trying to help with that. So this is also still available to
Yeah.
us.
I want to, go right
I
ahead.
was going to say, and I think the acceptance issues are dramatically different. In the old days, when I used to introduce the idea of IVF or donor egg IVF, it was like, that was a far out idea. Like, how do people really do this? Now people know these things. They walk in and they ask,
they're
they
educated.
expect.
Yeah.
Oh, and it's
Yeah.
so mainstream.
Yeah.
It's not something that's a wild idea anymore.
Well, if you go back to one of the stats, Dr. Mroueh, that you said about, and I won't go through the whole thing, but you basically said someone who's really trying every single day, 3 times a day, only has a 35% chance of, will only conceive 35% of the time,
When
right?
you're 18.
So we probably think it's under, yeah, and you're 18, not when you're 25, 35, 40.
Yes.
So the reality is the probabilities are already stacked against folks, and society probably has assumed that it's just so easy, so therefore that sort of acceptance of this is an issue and I need to deal with it has gotten better, which, like most things, is helping. And
Yes.
conversations like this help to advance it.
Good.
I want to pause and check to see if there's any questions that have come in.
What does the average appointment look like if you're like a male-female couple? Are you meeting with a male, a female? What does the first appointment look like?
It could be with either one of us.
So, the first appointment, we do get like a very detailed history. We do get a very detailed history on the couple, try to see what could be wrong, and then order the necessary tests.
And I'm sure part of that initial, to Phil's question, part of that initial consultation is probably what is comfortable for the patient or the circumstance, like you
Well,
said.
it's usually talk. I mean, sometimes people are concerned that they're going to be physically examined, but we
Okay.
don't typically do a physical exam in any first meeting. So we talk, find out what the couple's interests and needs are, and address them accordingly.
Great. Okay, great. Thanks, Phil. So I kind of asked this up front, but I'm going to revisit it. And as I've listened to the two of you, I feel like I could probably maybe attempt to answer it. But I want to understand for you what makes your work rewarding, because and you both smile so much when you talk about it. So clearly it is rewarding. So, Dr. Mroueh, what makes your work
You know,
rewarding?
it's so rewarding.
Probably babies.
I mean, first of all, seeing, that big bump, it's so rewarding. I mean, it brings like a big smile to our
Yeah.
face. And then most of our patients either will send us picture or more often will visit us with the
Yeah.
baby and holding that baby in our arms.
Yeah.
I mean, it's our baby too,
Yeah.
a little bit. It's
That's
like,
sweet.
It's really like, and then, I mean, I guess I've been in this field for so long. Now I see them going to college, and when I meet them, and oh my God, one of our, was a valedictorian at one of the schools this year, and seeing this young guy giving the speech and
That's sweet.
everything. It's a good feeling.
That's
It's
great.
a good feeling.
Dr. Hayes?
Yeah, oh yeah, we love seeing the happy families and the babies.
Yeah.
And, that's what makes all the work
Yeah.
rewarding and
it.
worth it. And we see women who come in and couples who are very upset and, they have difficulties with their relationships and work and the whole world seems wrong. And then they have their baby and the world looks very
Everything seems
different.
better. Everything's, it's
Yeah,
amazing how
they're
that happens.
entirely different people.
Yeah, yeah. Is there anything that I didn't ask that as you two sit here and think about questions you get asked every day that you think might be worth it for us to cover? And there doesn't need to be, but I just want to make sure I ask the question.
It's a little bit of a wild west out there for fertility treatment.
Okay.
And, patients need to do the research, try to understand exactly, from their physician why, what, and where. This is really important.
So I guess I want to end there, and then I'll say thank you. But so for someone listening who says, okay, now it's probably time for me to consider some kind of a deeper conversation about this, is it reaching out directly to your offices, or is this something that most patients get connected through their OBGYNs or their general practitioners?
It could be any of the
Okay.
routes.
Okay.
So, I mean, if they call us directly, they just call and make an appointment.
Okay.
If they want to work through their OBGYN or a primary care physician, they could ask for a recommendation or
Okay.
referral and call us.
But again, just remember, do not wait too long.
Yeah.
I mean, you've been trying for a year, for 6 months, nothing has worked. Just seek care. It never hurts. I mean, you might be just reassured that it's just fine and it's going to happen. But
Yep.
it's really good to ask for opinion of an expert.
That's great. Dr. Hayes?
Yeah, two more things that we should wrap up with is, number one, age is the number one influencing factor of success in getting pregnant, and that's the issue with waiting. Waiting too long is problematic. And some women find themselves in a difficult position. They say, well, I'm not married, I would prefer to be married, do I get pregnant?